Good morning. All right, so welcome to the Peripheral track at CVI. This is the Pulmonary Embolism session, and I am one of the moderators, Parag Patel, Interventional Radiology at Medical College of Wisconsin, and I'm joined by my co-moderator, Dr. June Lee.
Hi.
Needs no introduction. And we have a wonderful group of panelists to help with discussion and a group of 6 cases to present to spur that discussion. Do I see Dr. Castro here? Should ask before. There we go. All right, so our first presentation is Acute PE Failed Pharmaco-Mechanical Lysis from Dr. Castro.
Good morning, everyone. So I was tasked with presenting a case of failed pharmaco-mechanical lysis, and I really dig really deep to try to find a case of failed lysis. And not just my cases throughout the UH also as well, kind of record. And we're that good that we don't have failed pharmaco-mechanical lysis cases. So I have a case of partial success / failure, depending on how you want to see it, of catheter-directed lysis. And I think there's still a lot of learning points from this case. So hopefully we'll be able to have a good discussion overall. So this is a case of a 41-year-old woman with a history of morbid obesity with a BMI of 58. Active smoker, prior opioid abuse, history of a brachial artery thrombosis with compartment syndrome that required left upper extremity amputation, prior unprovoked DVT and PE, hypertension, HFpEF, COPD on home oxygen, 3 to 4 liters, also chronic lower back pain, who presented to us with shortness of breath for a week. She was previously advised to be on indefinite anticoagulation, but she has not been compliant with Eliquis recently. She has not followed with specialists. She's only been seen when she comes to the hospital for admissions, and because she's had multiple oral barriers to access care. At baseline, she was only able to walk only from her bed to the door of the room before needing to stop due to dyspnea for several years already. It's the reason why she mainly uses a wheelchair. So again, the reason why I wanted kind of to present this picture, this is kind of the functional capacity that this patient has, and this is her quality of life. On presentation, she has a heart rate of 120 to 140s, all sinus stack, blood pressure in the 120s, sat 94% on high flow nasal canals, so requiring more than she normally requires at baseline, 50%. Troponins were elevated, BNP as well, and a mildly elevated lactate. And when you calculate, there's a patient that comes in with an acute PE. When you calculate her estimated PESI score, she's actually into the class 3 intermediate risk category because of her lung disease, her oxygen requirement as well, and her tachycardia. But when you actually put it into the BABA score, she actually comes into the high-risk category, which means she's actually a risk of 42% of having PE-related complications. This is her CT of the chest. As you guys can see, again, you can't even fit her on the scanner because of her, kind of wide habitus as well. You can see a saddle PE that actually is occlusive in both PAs as well. So pretty significant clot burden explains her symptoms, and also evidence as well of RV strain with enlarged RV. This was an LV to RV ratio of about 1.7. And her echo, initially with contrast, what can you see? Nothing. It's really difficult to really appreciate what's going on, but when you actually use contrast, echo contrast, you can see the RV is definitely enlarged. It is moving, so there's some, kind of maybe only mild dysfunction, but definitely enlarged RV. But the question, looking at this patient who has, limited functional capacity rate at baseline, likely some chronic component of disease overall, coming in with an acute PE. So the clinical challenge in this case, how would we manage this patient initially? We started her on IV heparin. To make sure that she was in therapeutic range for anticoagulation for the first 24, 48 hours. And we wanted to see, we were hoping, really fingers crossed, that she would improve with anticoagulation alone. But she remained tachycardic with the heart in the 120s, 140s, still having a significant oxygen requirement, and also feeling short of breath, although a little bit of improvement compared to how she was at home, but still feeling short of breath, unable to lay flat. So in this patient that we have, as I mentioned, overall this kind of limited functional capacity at baseline, pretty large body habitus. I want to try to offer something that would help her, that will help her get back to where her baseline was, because I know I was probably not going to get her more than when she was before because of her chronic conditions, but at least get her a little bit closer to where she was at baseline, but also decrease her risk of complications overall. So my thoughts were, thinking about potentially thrombectomy, but in her case with a large body habitus, I would think she would be at high risk of complications from a large bore access. So we actually elected to do echos to bilateral PAs from a right IJ approach. She was somebody that would not be able to lay flat, would have a lot of issues overall remaining flat for the duration of the procedure. So we elected to do a right IJ approach, echos, which would be, take us like 10 minutes to do. Opening hemodynamics, a right atrial pressure of 18, pretty high PA pressure. So we see the PA pressure 90, 36, 62, and overall borderline cardiac output and index. So given her body habitus, the large clot burden, we decided to do TPA for about 12 hours, 1 milligram per hour in each site. And then when we reevaluated her at 12 hours, she's feeling improved, but still pretty tacky. Still high O2 requirement, the same O2 requirement that she was having. So our thought was, what do we do then? And that's where I would like to ask kind of the panelists what they think. What would you do then? Already you've had 12 hours of TPA. She's feeling a little bit improved, but still pretty tacky, still high O2 requirement.
Yulanka, that was a great case, very challenging. This patient probably has acute on chronic clot in her pulmonary tree, which makes these cases super challenging. You've tried 12 hours of TPA. If this is all acute, I would think that the majority of the benefit would have been realized right now. Given her body habitus, some of the technical challenges, I'm curious if you were to consider a mechanical thrombectomy approach, what therapies were amenable or available to you at the time?
Yeah, so I guess we have options, either return to, do we do mechanical thrombectomy? Some might say, do you do systemic lytics? Do you administer systemic lytics to see if you can help her? But in this case, we elected to actually do another 12 hours to continue the catheter-directed lysis, because I really did not want to get into the, to try to put her for thrombectomy overall at this moment. So we continued lysis for another 12 hours. And then after full 24 hours of lysis, she felt significant improvement. She told us near back to baseline. The oxygen requirement came down significantly, but still pretty tacky. That was my concern. Like, why is she so tacky still? Is the conditioning? Why is she so tachycardic? But we got her at echo that showed the RV was looking slightly better, actually really good function. If you guys see, the RV is actually moving pretty well, tap CF2. So I felt reassured, but still, with the heart of 120s, I do not understand what was going on. So what would you guys suggest?
I think it's important to recognize not to overtreat your patients, right? So although her heart rate is 120, she's showing clinical signs of improvement. The echo, as you mentioned, is actually improving. And actually, on the prior slide, my thoughts were, gosh, I really wish I could look at the PA pressures on 12 hours after infusion, so that can at least kind of help me judge how well are we truly treating the PE.
So this is a patient that you guys would take to the lab again, measure pressures, do a full echo, maybe do a PA angiogram?
I don't know. I mean, to be honest, so first of all, the experience that you have is very clear in these slides. This is someone who I would have been very hesitant to put on the cath lab table. It just screams decompensation. And I would have done what you did, which is small catheter lysis. And I would have kept going as you did. I would have tried everything to prevent putting a large catheter into this woman's PA. Did you follow fibrinogen levels, by the way?
Yeah, that's a good question. They all stay actually in the higher levels. They did not drop significantly. They were on the 200s, 300s fibrinogen.
So I think for me, if she felt better and was on baseline oxygen and was up walking around, I would probably just ride this out. I would still be a little hesitant. Do I think I could, if I had to get her through it and get a successful result? Probably. I'm just not sure the need to do it at this point.
I agree with what Matt said earlier, in that this is probably an acute and chronic clot. Anybody I see that's had prior DVT-PE, that's been off anticoagulation for a while, the thing that's in the pulmonary is not always fresh. I think taking this person for mechanical thrombectomy up front would have been risky with the PA pressures in the 90. So sometimes I'll do exactly what you did, and I'll do CDT for 8-12 hours, just to debulk some of the acute stuff, reevaluate. And at that point, sometimes the patients are a little more stable to then tolerate a mechanical thrombectomy. to get the chronic pieces that aren't going to go away with CDT. I think you can either do what Chris said and ride this out, or re-CT at this point and just see what you're left with. Because if the majority of the clot's gone on CT, then this I think you're done and just do anticoagulation.
Yeah, I 100% agree with these guys. So coming into this, when you see a big RV, someone who's hemodynamically in trouble and extraordinarily hypoxic, and then you see a CT scan where actually the clot burden was not extraordinarily impressive, right? So you know there's a chronic component both of probably CTEP and just some other chronic pulmonary disease. So your kind of expectations up front are a little bit less. I think if she was clinically sick at this point, then re-CT scanning her makes some sense. If she feels like she's doing better, and this is a person who just is chronically ill and is going to take a while to kind of improve vitally, then I think you can see that and give her a little more time.
Great job, Yulanka. I think patient's doing clinically much better. She was in high flow. She's down back to baseline. So honestly, I'm not sure if the heart rate necessarily all from the peak. She could be dehydrated, etc. And the RV, honestly, the function looks fantastic. At this point, I would just continue anticoagulation and hoping, address if she's dehydrated, etc., and just hope that she's gonna, get better over the next few days.
I think one of the things, when we're in a site where we have all the armamentarium, we want to make sure we're actually treating the patient correctly. The last thing we want to see somebody in the office later on, they're like, oh, they're still short of breath or not feeling well. So you want to make sure that, we want to make sure that we offer everything that we can to patients, but do it appropriately. So in her case, we did decide to repeat a CT. We just wanted to make sure we're not leaving a lot of clot burden behind. I did not want to take it to the lab again to, even to measure pressures or really do angiogram. But I just wanted to make sure, what we were leaving behind. And I don't know if the other one will play. So as you guys can appreciate, I wish I could stop it, but there's still some clot burden, not as bad as it was before, where there's still kind of a good amount of clot in the left and the right. But overall, even with the CT showing some residual clot, based on the clinical improvement, we decided to just continue to manage with anticoagulation alone. So as I mentioned, additional 2 more days of IV heparin. She was feeling significant improvement, went down back to her baseline requirements of oxygen. Heart rate improved, which was kind of our concern. Overall bridge to warfarin, and she's now hopefully going to be able to establish the pulmonary hypertension clinic. So key learnings overall for me in this case. Overall, with every potential intervention, we got to consider the ratio of risk benefits, the patient's baseline quality of life and functional status, to see how aggressive we want to be with patients overall. And this is our question: is there a role of radio imaging in patients that get catheterectomy lysis? Do we do it all the time, routinely, only if symptoms persist? We want to make sure we follow these patients overall clinically to see how they improve. And also the question, when to stop further lysis or even thrombectomy when we're in the lab. Is it the clot burden only? Is it the hemodynamics, or is it symptoms? But these are questions that we continue to address and continue to ask every day for our patients. Thank you.
Brilliant. Great job. Great job. I think this highlights the importance of us being more than just operators. For good patient outcomes, you need to be able to think and manage patients, and they will benefit just as much from that as your procedural skills. And I think all the right decisions were made here.
Yeah, I would agree. I think it's well established on the panel that there was a component of chronic PE here that we're dealing with. They weren't going to clear all of this probably, but to take the patient to the cath lab was a challenging endeavor, no doubt. I think you chose the right device. I'm curious on the panel, when we do use ECOS, we've been moving based on some of the trials to some shorter duration but higher dose. Is everyone still doing the standard 1 milligram TPA, which is what you did, and then continued for an additional 12 hours for 24 versus doing, say, 2 milligrams or even more for a shorter duration? Thoughts on that as an approach for ECOS and Lysis? I'm curious what the experience is there. Or are most people just doing thrombectomy?
I can just speak to our institution. So when we started catheter-directed lytics, it was based on the original Seattle 2 trial. We did everybody 24 or 12 hours as per their trial protocol at 1 milligram per hour. As the data came out for shorter and shorter durations, we've kind of moved to that. We have not moved to the higher dose unless we don't get a clinical response that we're expecting. You know, I always think that when you're doing programmatic things, the simpler you can make things, the better. And so I basically have given all of our operators 2 options, 4 or 6 hours, and with the option to extend if there's a clinical reason.
So I initially actually embraced the shorter duration protocol for a while. Recently, I've moved back towards doing an extended duration, especially if there's a large clot burden. I think it's important to recognize that it does still take some time for the mechanism to work for catheter-directed thrombolysis. So I think it should be a specific kind of patient-driven decision. If it's a patient who's high risk for bleeding, you may want to try to limit the duration. But if it's a high clot burden, you may want to consider extended duration.
Yeah, this was a great point to just, I was suspecting that most of the benefit from the TPA had been realized by 12 hours, but clearly I was wrong and there was a lot more benefit to be gained. But how much does the pulmonary artery pressures play into your role of how aggressive to be? This patient was tachycardic and the RV clearly looked better, but if you were able to sample the tricuspid valve and still get really high estimated pressures, would you go in and invasively check pressures and then decide to do mechanical thrombectomy, or is it still more of a waiting game? So as we've done some of the shorter duration single day treatments, we've gone to not bringing them back to the cath lab. We've just taken them out in the ICU. So we're not checking some of the same hemodynamic parameters. While you can take pressure measurements from your catheter in the ICU, we've sort of gone away from just strictly looking at some of those parameters as endpoints, saying that we've realized the gain and just give it a tincture of time. To your point, June, I think that you have to be mindful of, you did see improvement, you just may not see them normal initially.
All right. In the interest of time, excuse me. In the interest of time, let's move on to Tarek Hammad, who will be presenting to us the flip side: failed mechanical thrombectomy.
Thank you. Okay, no disclosures. This is a 19-year-old obese lady, history of depression, escitalopram. Started a month ago, came into outside hospital, with 3 months chlorotic back pain, and a week ago she started to have acute onset dyspnea, tachycardia, and dizziness. At the outside hospital, I'm sorry I don't have the CT images, but trust me on this, she has extensive central submassive PE with right heart strain on CT. Heparin drip was started. This facility, her vitals, the blood pressure was okay. She was tachycardic with minimal activities walking into the ED, but at rest she remains tachycardic 110 to 120s. O2 sat initial was 85%, with 4 liters up to 95%. Troponin is the old one, 0.082. Cutoff is normal, less than 0.01. She's acidotic, we didn't have lactate, but she has an iron gap of 21. Her PACE score 59, she's low risk class 1. I'll come back to this at the end. So at the outside facility, they attempt percutaneous mechanical thrombectomy, and they couldn't get anything out. So basically, it was a failure. But they did right heart at the same time, and she has a past pressure of 72, which indicates some probably chronicity to this. And she has a SAT of PA63, giving us cardiac output of 4.4 and low cardiac index of 2.1 assumed FIC. She was transferred to our facility en route. We actually, as a per team, the transfer call was initiated, and as a per team, we conferenced and we, over Zoom even before the patient came to us. And, here's her echo images from the outside facility. You can see that on the left panel, the 2-chamber view with the RV at the bottom and the LV at the bottom, RV at the top. And you can see the septum is really flattened and the LV is kind of squished. And you can see on the right side panel that RV is dilated, at least moderate, and it's not squeezing as good. So patient was discussed with the per team, and at our facilities, this include vascular medicine and pulmonary all the time colleagues, great always collaboration and help. And in this specific scenario, we involve our CT surgery colleagues as well. So decision was made to proceed with another attempt thrombectomy, just to make sure that this was done the right way. And actually, we used a different device than the one was used at the outside facilities. This was back in 2020. So, on the left panel, I don't have all the image, but we have tried hard using 24 French float retriever catheter. And we went also with a 20 curved inside the 24, right, left, we couldn't get any. And this is I was actually a fellow with Dr. Shishehbor in this case, 1 month into fellowship. And this is the angiogram. You can still see that she has, almost a huge, large burden of clot in the distal left and right PA. And the right side extend almost to all lobes, but definitely the most impacted would be the middle and lower lobes. And in the left side, most impacted would be upper and mid lobe, but basically all lobes are involved and really huge amount of clot. So once we were done with the procedure and we're about to remove the dry seal sheet from the vein, she actually vasovagaled. She had a brief episode of bradycardia and hypotension. She recovered with fluids, with atropine and 1 dose of epi, and she became stable again in a matter of a few minutes. So what's the next step at this time? So she remains tachycardic, 110, 120s. She's going for it for oxygen. We saw her an angiogram. Now she failed 2 attempts of mechanical thrombectomy. So PERT again. So basically we met again and decided that this patient needs to go to the OR on an urgent, emergent basis, she underwent open embolectomy with Dr. Abu Omar, one of our top-notch surgeons at UH, and this was the same day. And this is a clot. I'm sorry, I don't have a ruler for reference, but those were a huge amount of clot, and you can see they're all white, which indicate chronicity. Probably a clot been going on since pleuritic back pain, which has been 3 months. And this is an echocardiogram. So you can see on the left side panel that LV is open. Still the septum is slightly flattened, but that LV is more relaxed. And on the right side panel, the RV size is smaller now, almost slightly less than the LV, and is moving much better. So patient was discharged home about a week later. This was the 27th of July. She was discharged 4th of August on anticoagulation. We took specimens just to make sure it's not a sarcoma or something, unusual. And indeed, she had the thrombus. It was a thrombus. And the hypercoagulable workup as the outpatient was negative. In fact, she was seen last week, which is 3 years later, by one of our vascular medicine colleagues in the clinic. And she was doing well in anticoagulation. And she lost some weight. She went from BMI 48 to 40. So just a quick comment about PESI score. I always feel like I have to make a comment. So our patient, as you know, she was PESI, class 1. I really don't like PESI score. I feel it's not specific to PE, and I think there's a huge difference between high-risk patient versus high-risk PE. And this PESI score is more specific to the patient, not necessarily to the PE presentation itself. So sometimes it can be misleading, like in this patient saying, oh, PESI of 1. So I just gave 2 examples. The left side, 85-year-old. If you plug the numbers, he's male. He has history of cancer, heart failure, chronic lung disease, and he has normal vitals. So he has a 2 by 2 millimeter P in the most distal branch, his right, lower lobe. He'll get a PESI of 5, and very high mortality. Close to 30% 30 day. If you go to the right side, our patient, she's very sick, tachycardic, hypoxic, but she's young, she's female, she has no risk factor. She get PESI 1. So I really feel like PESI is misleading, and honestly, I don't like it at all. Just to touch on the importance of PERT, this is a paper we published. This is on now old data. It's about 5-year-old. When this was in between January and September of 2019 at UH, and our experience, including Dr. Shishehbor, Dr. Lee, and the rest of the team. Dr. Carmen, she's here as well. Just to see, how these patients with PE were managed. So we included all patients with CT-proven PE. With right heart strain, and there were about 220 patients against old data 5 years ago from 2019. And you can see the people with PERT, only about 20% who got PERT activated. I bet now we're probably above 95% activation rate. But back then, we were probably about 20%. So 47 patients got PERT, 173 got no PERT, with a big burden P and RV strain. But, and if you look at the left panel, that figure, you can see the non-PERT group, all of them got anticoagulation regarding of their PESI. Again, I don't believe in PESI, but all of them got anticoagulation. And they probably, if you look, very few got IVC filter, and I think only 1 patient got echo. So really, majority of the patients were treated with only anticoagulation, and only maybe 1 to 2% got treated with some sort of different or advanced therapies. While if you look at the 47 patients with PERT, and again, regardless of PESI, which tell you PESI really is not helpful, that even PESI-1, if you look with the blue color, dark blue, you can see even with the PESI-1, 1 patient got ECOS, 1 got thrombectomy, and 5 got anticoagulation. And across the board, you can see 1 got embolectomy, surgical, and so a lot of patients got different modality of treatment, and this was, impact of PERT, that this was more, like Dr. Lee alluded to, that, patient-specific and individualized treatment rather than just, treat everybody across the board with the same treatment. This is the same paper we published. So on the left panel, tell you the utilization of advanced therapies among PERT and non-PERT. So if you look at the light blue, the use of advanced therapies, whether it's scattered, direct lysis, or thrombectomy, was about average 1%. If you look at the pink color, this is a PERT group, almost 25 to 36, quarter to third of the patient got some sort of advanced or different treatment. And if you look at the middle and right side panel, this is the impact of PERT. Again, I'm not talking about the impact of advanced therapy. I'm talking about the impact of PERT activation and PERT decision on the treatment of this patient. So if you look at the composite endpoint of mortality, within 30 days, major bleed or readmission, those who did not get PERT activated, they were up to 60%, very high. More than half of the patients that got some sort of complication. If you look at the PERT patients, they're half down. They're about only 36 patients. And it was significant by the Kaplan-Meier curve at 90 days. So again, key learning points for this is PERT, PERT, and PERT. That's all I have. Thank you so much.
Great case.
Great.
Go ahead. So, I've been fooled like this a number of times, and that there's nothing in the history, there's nothing in the imaging that tells you this is going to be chronic, other than the fact that it was failed at the other facility. Anybody have any ideas of how we predict this? I'm fooled. There's chronicity of symptoms. There's PA pressures. There's some description of what it looks like on the CT scan to give you some clues. But again, I think I still find myself pretty terrible at trying to decide who's chronic, who's acute, who's mixed.
Thank you. Honestly, I think history is key, to be honest. Like everything in medicine, history and exam are key. Actually, I went up to the note from the outside facility, and from, it did say that patient had a 5-day, actually, in fact, 3-day history of symptoms. And then one of our vascular medicine colleagues who was a patient, that's the one mentioned 3 months of pleuritic back pain, and then acute onset in dyspnea, etc. So I think the pleuritic back pain probably was a clue that this is, more chronic. So I think, honestly, history is a key, and it does play a big role. I just had a PE, somebody in-house, that we did thrombectomy, and everything came out. When the PE is so fresh, matter of hours, I mean, it comes out right away. When we struggle, that's, indicate that this is chronic, and it gives us a very hard time. So I think history is a key in determining, but sometimes it's hard even, patient poor historian, etc.
I would add a couple quick things. I think history is key. I also think we have to understand that these are dynamic and fluid processes. And a lot of times, these folks have a lot of chronic clot and have an acute clot that actually brings them into the hospital. And so, frequently they'll have subsequent events, and the last event is just what reached their threshold to come in. And I think we kind of have to understand that. I think this was a great case, a great illustration of what kind of multi-specialty care can provide a patient. I would add one thing on prior failed thrombectomies. I'm kind of a heavy into imaging guy because I do a lot of structural. And in these folks who people have had trouble on, I usually put their imaging into our structural software. I recon them. I get fluoro angle so I know where certain branches take off to where my catheter is going to be in position to the clot, so I can make sure at least I'm coaxial to it, because that's a very hard thing to do on angio. For this thing, it probably wouldn't have mattered, but I would suggest that in these cases where other people have tried and failed, use all of your resources that you have.
Yeah, great points. So a few things. Number one, yeah, your point on PESI is a good one, right? What is PESI really calculating? It's a score of 30-day mortality. I mean, you take a 85-year-old with multiple comorbidities, their 30-day mortality is going to be higher. I mean, it's not meant to be a judgment of who's going to benefit from pulmonary thrombectomy. A 19-year-old is going to be low risk, even with a significant PE. Regarding this one's very strange because on your angiography, there is a mobile component to that clot. So I saw the consistency of it on the table, but it was certainly not attached to the PA wall like you would expect a chronic thrombus to be. I bet in 2024, if that patient came in, we would probably get that out, just based on the experience that we've gathered over 4 years. Dr. Stegman brings up a very good point. When you fail to remove clot, particularly clot that's mobile, even if it's aged, is because your catheter is not pointed in the appropriate direction. And usually it's because your wire needs to be somewhere different so that your catheter can point in the appropriate direction. Most often people fail on the left PA because they're not where they think they are. And that often becomes obvious if they just swing the camera over from LAO to RAO and they see that their wire's in some small branch when they thought it was in the posterior basal. But it can happen on the right side too. So I agree, use all of the imaging available, consider multiple angles. If you're not getting it, maybe place your wire in a different spot. I bet you a T24 would get this out now.
Thank you, great points. Actually, I just saw brief images, but we spent like about an hour and a half with Dr. Shishehbor trying to get this. We got multiple views, multiple catheter, we got the 24 and the 20 curved, and we couldn't get it out. And the clot from the OR was very wide, so I think it is very chronic. It is very chronic. There might be, like Brian said, some acute and chronic component, that may be led to the acute presentation, 5-day dyspnea, but I think the clot probably were going since 3 months pleuritic back pain.
Yeah, I'm not arguing it's not chronic, but you can pull chronic clot through those catheters if you have them pointed in the right direction. You'd be amazed.
Great points by all, and I think emphasizes the imaging and perhaps utilizing imaging guidance opportunities there to make sure you're in the right spot with the new devices to be more effective with even more subacute or chronic clot. Let's keep us moving on so we can finish on time. Our next speaker is Dr. Samuel Horr, QPE failed systemic lysis.
Thank you for having me. So I didn't have a great case of failed lytics, so I'm going to present a case that has background of failed lytics, and I'll explain in a minute why I picked this case. But I'm going to present a case of catastrophic PE, or crash and burn, referring back to the Intermax 1 risk stratification. This is a 54-year-old gentleman who presented to an outside ER. He had some syncope after using the restroom. He was short of breath for 2 to 3 days prior. Notable past medical history is really type 1 diabetes that he's had for 30 years and tobacco abuse. So on arrival in the ER, he was tachycardic. He was a little tachypnic, but not hypoxic. He didn't have any signs of heart failure, and he was really just dry. These are his labs. His creatinine is 1.6, his bicarb's 20, his glucose is over 600. His troponin was actually within normal range, and they actually did a CT scan trying to figure out why is this guy in DKA, trying to figure out a cause. His D-dimer was elevated. So CT there showed he had a small moderate PE in the left lower, but no RV strain. On an ultrasound, he had a large occlusive left femoral DVT extending down to the popliteal. So he was actually transferred to our MICU for DKA primarily, thought to be triggered by a small low-risk PE. He was given insulin and fluids, and heparin was started prior to transfer. When he arrives to our MICU on first assessment, talking to the EMS, he was actually over the car ride, became much more uncomfortable, more tachypnic. He's now hypoxic with oxygen levels going up. And a stat ABG was done at the bedside that showed he's now very acidotic, his lactate's 17, and he's clearly changed in presentation from where he was at the outside ER. So on prepping for resuscitation, essentially a code was called, even though he was not coding at that time, but after that ABG, a code was called to mobilize people to the bedside, and on prepping of A-line, central line, patient suffered a PA arrest. He coded for 3 minutes, got return to spontaneous circulation, however, quickly then had a PA arrest again. So ECPR was used, so we have a very robust ECPR program now at our hospital, and in under 20 minutes he was put on VA ECMO at the bedside. So 16 hours later, he's now on minimal pressors, but when they go to do an ECMO wean, he fails pretty miserably. And this is his echo during the time of weaning. So whenever we do an ECMO wean to try to see if the people can be liberated, we do echo with that. And you can see here his right ventricle is very dilated, very hypokinetic. His LV function is actually down as well. It's 35%. Not well shown on this picture, but. So astutely, a CT was done, which you can see here. Not massive clot burden, but you'll see a large appearing fresh clot sort of going to the right lower. This left lower was, as you can see there, was what was present at the outside hospital. This right clot was not there in the initial CT scan done. And you can see it extends into the right upper as well. So this is just a sagittal view here for people who like sagittal views to help CT plan. You can see the VA ECMO cannula there at the RA IVC junction, and then you see the large clot. Again, it's not a saddle. It's not the most impressive clot burden, but clearly this guy threw a clot probably in transfer, and somebody who was already sick with DKA was all he needed to now become catastrophic. So the clinical challenge here is we have a patient with now high risk or what's deemed now catastrophic PE after the PERT Consortium most recent analysis of defining what is catastrophic PE in people with cardiac arrest, high vasopressor use, or mechanical circulatory support. And this gentleman now has a very high mortality, and that's in the PERT Consortium data, it's 42% in hospital mortality. So this is not a failed lytic case yet, but the reason I brought this up is we have now created some mobile ECPR for our network, and so we have a central hospital with the ring hospitals, and we've started ECPR going out to other hospitals and cannulating in the field. And so we have 2 cases actually within the month before this case that were high-risk catastrophic PEs in which they got systemic lytics at the outside hospital, but again, failed to bring the patient back, still coding. We went and mobilized ECPR, cannulated in the field, and both patients had bad outcomes. One had a neurologic bleed. We were able to cannulate them, get them back hemodynamically, but had a large intracranial bleed and died. And the other person had a large intra-abdominal bleed in the setting of lytics prior to ECMO cannulation. And so this is not failed lytics, but from a programmatic standpoint, we have not had great success in the very recent future in using lytics and ECMO support for these catastrophic PEs. So the clinical challenge is now what to do. So we have a catastrophic PE patient that has failed ECMO challenge or ECMO wean, and these are our options. So we could do anticoagulation and chill. The patient's fully supported, they're hemodynamically doing well, the RV is fully supported, they're oxygenating. We have systemic lytics. We already have cannulated, so maybe the risk of groin access site complications and things like that are going to be less. There's catheter-directed lytics, which may be less TPA, you have less complications. Surgical embolectomy and mechanical embolectomy. What would people do here? Because I don't think there's a right answer.
Sam, great case. These patients who have metabolic derangements in addition to their acute physiologic derangements of the RV are really challenging to treat, and kudos to your team for crashing this patient. Wondered, just talking to the panel, if you, if others could just talk about their capabilities for a patient like this and their decision to do VV versus VA ECMO.
Yeah, we would definitely VA ECMO this patient because of the hypotension. Any hemodynamic collapse is going to VA ECMO for us. We are very good about placing patients on VA ECMO who present to our ER or enter hospital and then arrest. In fact, we will do that before we even give systemic lytics. But where we're bad at it is when we are not there when they arrest, or they arrest at an outside hospital, they often do end up getting lytics before we get them on ECMO. And as you mentioned, that is a bad combination.
Yeah, I can have a slightly different view, just because in our hospital, we do a fair bit of ECMO, but ECMO is a endeavor. And it's hard, it takes us a solid 20, 25 minutes to mobilize an ECMO circuit. So I can tell you, if this was in my institution and it was when I was there from 8 to 5, we would give the person some epi and take them to the cath lab, and I would quick do mechanical thrombectomy and put it in an RP and Pella, and if they flu, great. If they didn't, we'd put them on ECMO. Because I can do all of that usually before we can actually get ECMO. If it was at night, it would be a challenge. They would probably get systemic lytics. We would have the cath lab activated. We would try to get them onto ECMO soon, but that can be a challenge. And I think that's these type of cases, it's very institutional driven. We're a hub and spoke model hospital, and we have probably 20 hospitals that send to us. And whenever they come in, they get uniformly systemic lytics because that's the only thing that we can do.
Yeah, I agree with Brian. It is very resource heavy, ECMO. And in our hospital system, so we have essentially a really large hub and spokes model. Our central campus does have ECPR, but the outlying hospitals technically can do cardio help, which is essentially ECMO. However, it still requires us to mobilize the entire perfusion team. So we can certainly place ECMO in the cath lab, but to place it in the bedside is a little bit more challenging in the peripheral hospitals. So I think depending on the practice of where you are, that might not necessarily be available. Getting back to your original question of which strategy to do, I think that really depends on your system's expertise, right? So in our institution, we would probably do mechanical thrombectomy, but that depends on whether or not we have those capabilities in the hospital system that you're in.
Agreed, mechanical thrombectomy.
Yeah, this patient would have been too sick to go to the operating room for a sternotomy and stuff, so they would have need to survive the Darwinian death challenge of mechanical thrombectomy, and we'd deal with any residual thrombus and kind of the aftermath. But as a life-saving thing, this patient would have got VA ECMO and mechanical thrombectomy at our center.
Yep, agreed. Mechanical thrombectomy. The one thing I would comment on, Sam, this was a great case of clot burden is important, but where that clot is more important. And, they essentially occluded the perfusion to their right lung. And no matter what they have for clot burden in the central PAs, it nearly doesn't matter because they essentially have occluded the perfusion to the right lung.
So great. This is the discussion we had. Now we're stable. We can have all these discussions about what to do. I have data on a little bit on this, but for the sake of time, I'll skip through. Our institution, we feel very strongly the longer ECMO runs are not what we want. We want to shorten ECMO run. We want to get them off as soon as possible. So anticoagulation and hangout is not the ideal. There's some Korean data on just ECMO only for PE, and mortality rates are still 20 to 30%. Systemic lytics. Again, we've had some bad outcomes recently with that. There's some Taiwanese data looking at it that it actually is useful, and at least in their series, there's less than a 20% mortality in those patients compared to those who did not get ECMO and lytics in the catastrophic PE. There's a group out of Baltimore that's published 83 patients in ECMO and PE, but they found no improvement in outcomes in patients who then got systemic lytics. The catheter-directed lytic therapy, I think there was only about 12% of the patients a little less than 20% of the patients in Seattle 2 are actually high risk, and most of those, like 10% bleeding rates, so not ideal. Surgical embolectomy, there's actually good data for surgical embolectomy in these cases. There's a series looking at, out of Europe, looking at those who got ECMO with TPA versus ECMO, and then surgical embolectomy. And had much better outcomes with surgical embolectomy. But again, you still see 20 to 30% mortality rates. And then mechanical thrombectomy, there's the FLAME data, but really if you look, only 3 of those patients in the study actually got ECMO and the FlowTriever arm. And so it's hard to say whether that works, but all the people who had SkyShock D&E in that study actually survived in the FlowTriever arm. So maybe a potential benefit, thrombectomy. This is the series that June was part of, and Mehdi, who looked at 9 patients who had this happen, and again, 22% mortality rates. So our institution likes to get people off ECMO fast, and so that's exactly what we did. This is the PA angiogram here. You can see large clot burden, but all very distal, like Brian said. But it's very occlusive. So it's heavy clot burden, sort of in the more distal vessels, nothing very central. So we took a 24 flow retriever up. Unfortunately, did not get a great result with 24 flow retriever. As you see, I would get the catheter down there, but I couldn't get coaxial and get into the vessels deeper. So we actually did a sort of a mother-daughter with the 16 French flow retriever through the 24, and actually we're able to get all the clot out using that sort of technique where we can actually get down further. This is the clot pic that everyone loves to see. It was all fresh clot. 36 hours later, he was off ECMO and discharged on post-op day 6, and this is his ECMO wean. Echo, as you can see, his right ventricle is smaller. It's now, even despite being on ECMO before, it was very large and not decompressed. Now you can see it's much smaller and better function. So key learning takeaways for us is that catastrophic high-risk peak, there's a high mortality, has to be initiated rapidly, whatever you're going to do, and it really is about facility capabilities. I know you guys mentioned that. That's really what we've moved towards, and our goal, at least at our facility, and I've done this now a number of times, is short-term ECMO to help support these cases, take them to thrombectomy, and actually explant ECMO in the cath lab. And so we'll put smaller 16, 20 French cannula, instead of a 20 French ECMO cannula, put a 16 French ECMO cannula in, arterial with a 20 French venous, pre-close them, do mechanical thrombectomy, and then explant ECMO in the lab. And it's worked pretty well for us so far for these really high-risk patients. And then we didn't talk about how to do thrombectomy and ECMO, which has its own challenges, and we can talk about it another time.
Great. Any comments from the panel? I think we have to catch up slightly, so I'm going to introduce myself. Okay, we are changing paces quite a bit here, so let's talk about some novel devices for PE. Unfortunately, this won't be case-based. It's more of a show and tell. There we go. All right, so think of PE devices as 3 giant buckets. One is catheter-directed thrombolysis, large bore thrombectomy, and moderate bore thrombectomy. Thus far, we've really focused a lot on large bore thrombectomy so far, but first let's talk about catheter-directed thrombolysis. Currently, we have ECOS that was presented in the first discussion here. So what are the things that we can improve as interventionalists, interventional radiologists, interventional cardiologists to help improve the efficacy of catheter-directed thrombolysis? So really what we want to understand is the balance of TPA dose. You want to provide effective therapy, but also minimize bleeding risk, and then shorten the time of therapy if you can. So two different catheters that are currently in the study phase. Thrombolex is available actually commercially. This is the Bashir catheter that has a nitinol basket. There's essentially 6 struts of nitinol wire along with infusion ports, 8 infusion ports within each wire. So a total of 48 infusion ports. And you can see on the very top right corner, that's how the TPA is actually pushed out of the catheter. When we perform this procedure, intraprocedurally, you would actually give 2 milligrams of TPA already, and then leave it infusing for about 5 hours. Over the course of 5 hours, you give an additional 5 milligrams of TPA, and that's per side. So if you do 2 sides, then it's 14 milligrams total. And I put down the dimensions of the catheter here. You can see on the diagram on the bottom, essentially this basket would encompass the entirety of the primary PA and allow apposition against the clot. What has been shown is that with the Bashir Lysis, we are able to decrease the RV to LV ratio at 48 hours compared to baseline. Rescue 2 is currently being studied. Rescue 2 is the on-table hemodynamic assessment. So the goal is actually to complete the procedure in the cath lab or in the IR suite and not have to do the subsequent 5-hour infusion. So that's currently undergoing investigation. Second catheter, I actually thought this was very exciting when I saw it, and it pertains to my question of how can you monitor PA pressures while you're treating these people. So this is the Flow Medical catheter, and it actually has a small port right here, right by the basket, that's a fiber optic sensor that tells you the hemodynamics real time. So you can track your PA pressures. So if your PA pressures are dropping, it's a sign that your clot is actually dissolving enough, and perhaps it's time to pull the catheters out. It's currently still in its early stages. They did receive the funding that was necessary, so currently they're undergoing further design modification and ultimately planning for our first in-human trial, probably in 2025. Let's move on to large bore thrombectomy landscape. Oop. How do I go back? Okay. So the goals of really optimizing large bore thrombectomy for the operators in the room, you want to try to optimize the delivery, so the catheter has to be deliverable, even though it's large. You want to decrease your procedural time and the complexity of your procedure, and you want to try to minimize blood loss. So the first catheter that I'm going to discuss is the AlphaVac catheter. Here you can see there is a funnel at the very tip, so it actually opens up to a 33 French mouth, essentially. So that gets unsheathed into the clot itself. There's a curved navigation, as you can see here, so that you can engage the left and the right pulmonary arteries sequentially. There's a handle that you actually squeeze to allow the actuation, so to build the suction. And you can actually limit how much you pull, so that's the way to minimize blood loss, is you can do smaller pulls to test whether you're on clot, and you can do larger pulls when you do believe that you're on clot. The Apex AB was presented recently by Dr. Keeling at Sky Scientific Sessions. This was the trial looking at the safety and effectiveness of AlphaVac in patients with intermediate risk PE. Enrolled a total of 122 patients with 25 sites. And what they reported out was that the mean procedural time was, on average, about 37 minutes only, and at 48 hours, very similar to other trials, the average RV to LV ratio was reduced. There was a reduction in the clot burden by Miller score, and then adverse events at 48 hours, there were actually 5 major adverse bleeding events. No thrombolytics were required, though. One patient presented back within 30 days with symptomatic PE recurrence, and there was no mortality reported. This device is now approved actually for PE use as well. The Aventis thrombectomy catheter, as you can see here, is a fully integrated system that actually does not use a dilator at all. So the device is actually designed with a slant on its catheter, and it uses a navigation catheter embedded into it that you can move in and out to direct you into the right and the left pulmonary artery. There's a built-in clot canister that actually allows you essentially to seamlessly withdraw the blood and the clot and then return it almost essentially back to the patient. And then an aspiration syringe that is built into the system. I'm running this trial with my colleague, Dr. Sabre. We are enrolling, total number of patients enrolled plan is 120 with about 35 sites in the United States. The primary objective, like every other study, is to achieve a RV to LV ratio reduction at 48 hours, and obviously looking at safety outcomes as well. This is actually a case that I performed actually on Tuesday before coming here. The Truvix Symphony catheter is a little bit different. So far, we talked a lot about more aspirational catheters that actually rely only on manual aspiration from the operator. So now we're moving on to catheters that have a little bit more mechanical aspiration, but they're still large bore catheter. This is a catheter that has some directionality, and it's got a motor that is on, so it allows suction, and then there's an additional that ProHelix mechanical assist that essentially agitates a little bit on the clot, so it helps it come into the device. And this is an example of a case that was treated by Dr. Bechet. And you can see here the system is created such that the clot actually comes into a canister right at your hand so that you can visualize as you're pulling back. It does come in a 24 French system as well as 16 French system so that you can go into the lower branches as well. The Innova Laguana catheter, it's a mouthful, but has a large catheter and also an additional clot retriever system, that little cage that you see, essentially is mobilizing the clot, and then you can suck out the blood suck out the clot. And here's a nice case from John Moriarty showing the utilization of the Innova catheter. Currently, the trial is not enrolling yet. The Clot-Hound Ace Gold PE catheter is a little bit different, actually. So here, what you'll see, the distal port is this port, and there's actually a basket that sits in the distal aspect so that you don't embolize. And then what happens is that there's a more proximal basket that essentially agitates the clot, and then you aspirate it back. Again, this one's with a syringe. And then lastly, the Althea medical pulmonary embolectomy solution is very similar with a basket as well as a mechanical removal system, in addition to a large bore catheter. So moving on a little bit to the moderate bore thrombectomy catheters, again, very similar goals here. You want to optimize your delivery, you want to decrease your procedural time and complexity, and ultimately minimize blood loss for the patient as well. This is the E2 helothrombectomy device. And you can see here, there's a curve on the device so that you can direct and also swing to different branches. There's a funnel that expands to 24 French, and then inside it, I believe it is that agitator. It's not moving, but the agitator actually moves so that you can pull more clot into your catheter. And this was presented by Tai Kobayashi at SKY Scientific Sessions in May. Again, showing dramatic reduction in RV to LV ratio, very similar to prior thrombectomy trials, and then a reduction in the Miller score as well. Acura medical thrombectomy system, similar concept. So there's a funnel that opens up to 30 French system, and then the mechanical thrombectomy on the end of it. And this was actually a first-in-human trial with 5 patients that was performed in the Republic of Georgia. This was presented by Dr. J. Matthews at VIVA 2023, which again showed RV to LV reduction. And these are the examples of some of the clots that were extracted. You can see actually there's some chronic component to some of these clots. You can see the white fibrin on it. So to what it's worth, these pictures at least suggest that it may work for subacute clot as well. Lastly, I don't have any cool pictures to show for this one, but this is an interesting catheter. It's called an ICE catheter, which actually uses hydraulics. So there's a saline flush that creates a vacuum charge, and there's essentially this charge that kind of sucks the clot into the catheter. The goal of this is actually to reduce blood loss and also decrease the bore size of the catheter. But I think yet more to come on this mechanical thrombectomy device. And then Magneto actually has been around for a couple of years now, so you may have actually heard of it. This combines the mechanism of a suction catheter, as you can see here, but along with it, a charged electrical wire that actually attaches to the clot. So what happens is that the clot gets attracted to the wire. You pull, you can agitate it a little bit, and then with the suction component, you can aspirate it into your catheter. It was first this eTrieve trial, the first in human trial, was presented in 2023 with a total of 10 patients enrolled in European sites. Again, RV to LV ratio is elevated at baseline, and they did show improvement to 0.97 in 48 hours. Procedural time was a little bit longer. It's 140 minutes, and the EBL was 240 cc's. No major mortality or no major bleeding were noted in the 10 patients, although there was 1 patient that came in with recurrent symptoms. There is a plan for eTrieve 2, but it's not yet recruiting. So in conclusion, a lot of devices out there, many still undergoing investigation. And the primary goal of new devices is, again, to reduce blood loss, to reduce procedural time, and improve the ease of use for the operator. However, I would say that in 2024, we still need a lot of clinical outcomes, right? So that's why it's important for us to continue enrolling in trials such as HI-PEITHO, PEERLESS-2, and PE-TRACK so that we understand beyond just an RV to LV ratio. We need more data in terms of what happens to the patient after the procedure. Thank you.
Thanks, June. Any comments, questions from the panel? Clearly tremendous interest in developing devices although we don't have uniform guidelines in treating all these patients, which is the challenge to your point and the importance of the clinical trials.
June, with all these devices coming out, assuming that we have data to say we are affecting clinical outcomes, where do you see this landscape in 5 to 10 years? Do you see us having 40 devices that we can all choose from, or is this going to pare down to a few devices that are very effective?
I think we have to be realistic in terms of cost of healthcare, right? So we have all these new toys, new devices coming out. There's no way that a hospital system will be able to stock 10 different thrombectomy catheters. So I think at the end of the road, assuming that the clinical trials do support using catheter-based therapies for our intermediate high-risk PE patients, I would probably visualize that most hospitals would gear towards 1 or 2 thrombectomy devices, maybe a moderate bore size catheter, a large bore size catheter, and then having an option for the catheter-directed lytics. So akin to what we're doing now, except I think everyone's going to essentially pick their favorite catheter.
June, do you know if any of these companies, obviously they have to prove safety and efficacy, but is the FDA requiring any of them with these IDE studies to look at 6-month quality of life outcomes? Or?
No. So the benchmark is actually against old trials. So unfortunately, it's the world that we live in currently. So all the IDE trials are actually comparing RV to LV ratio as the benchmark.
Great points. Thanks, June. I want to keep us on time. We have 2 more talks, cases, and discussion left. Our next speaker, again, Dr. Yulanka Castro, will be up talking about mechanical support in PE.
Perfect. Thank you so much. So continuing on the line of mechanical support for patients with pulmonary embolism. So this is a case we'll be starting of a 28-year woman who presented with shortness of breath in a syncopal episode to an emergency room. She was found to be immediately in respiratory distress, needing an urgent intubation in the emergency room, believed to be from angioedema causing airway obstruction. And this was because she had a history of recent tonsillitis with abscess that was complicated with a right atrial thrombus, a current smoker, and has a family history of venous thromboembolism. However, she was, after intubation, moved to the ICU, but hours after, noted to have significant hemodynamic decompensation, requiring high-dose vasopressors, pre-tachycardic, needing high-dose levofed and epinephrine to sustain a blood pressure, and still having difficulty with ventilation, mechanical ventilation. Elevated troponins, VMP, lactate, as well as her creatinine. She was ultimately found to have a pulmonary embolism with a pretty high PESI score. We know we've talked about the difficulties with PESI score, but even with this, noted to be class 5, very high risk, with a pretty high risk of mortality at 30 days. And this is her CT scan that was obtained. Pretty high significant thrombus burden bilaterally overall, and large RV ratio. Oh, sorry, the image is glitched. But significant thrombus burden bilaterally. Her RV, as you guys can appreciate, pretty large dilated RV that's suffering, compressing on the LV, reason why she's so, hemodynamically compromised at this moment. So large RV, compressing the LV, limiting the LV flow. So given her presentation, again, we have somebody here with clinical pulmonary embolism, that's significant distress, needing high-dose vasopressors. For this reason, we decided to place patient on ECMO cannulation for hemodynamic support, via left CFA, CFB, antigrip infusion sheath, and the left SFA. Overall, during the procedure, we wanted to also perform pulmonary embolectomy as well, with care to avoid suction of air into the circuit. And with this procedure, we were able to actually improve our hemodynamics, which we can see pre and post improvement of our PA pressures, and with a preserved cardiac index, again, all of this on ECMO support. So able to do safely a pulmonary embolectomy overall and sustain this patient throughout the procedure who was hemodynamically unstable. She was able to be weaned off ECMO pretty quickly, post-operative day 2, extubated the following day, renal function improved, APLA was negative, started on oral anticoagulation, and was able to be discharged home on day 9. Again, presentation that was pretty difficult, pretty catastrophic, and able to be improved with the correct support and the correct procedure in order to remove the obstruction. On her echocardiogram prior to discharge, we see how the RVs already significantly improve. And then on follow-up, we can see how the RV is already back to baseline, which is really important in this 28-year-old. And then we talk about high risk or massive PE. We know we saw this graph already before about in-hospital mortality. This is kind of the current data from the PER consortium on patients with high risk PE. The overall mortality is considered to be around 20% on current data for reports from sites that report to the PER consortium overall. That means sites that are have active PER teams and actively treat patients with pulmonary embolism. But we see that those patients that actually have what we call catastrophic PE, that means those that need high-dose suppressors or have cardiac arrest, the mortality goes up to 42%. And that is because of what we see in this famous graph of the RV death spiral, where the increased RV afterload leads to RV ischemia, RV dilation, which then leads to decreased RV output and decreased LV preload, leading to hemodynamic decompensation. How do we address this? So we got to address this RV dysfunction. And the main goal is to offload the RV. And for that, we need to do two steps, and that is resolve the mechanical obstruction. That's what we talk about, thrombectomy, embolectomy, and decompress the RV in order to be able to improve the RV afterload. And what are the strategies to do this? We talked a lot about VA ECMO in this session this morning. And the goal of VA ECMO overall is to decompress the right ventricle. Okay, so we want to decrease the RV preload, then move it to the oxygenator, oxygenate the blood, and then return it back to the systemic circulation, which again will promote systemic oxygenation, support the patient while bypassing the RV. Okay, so that way that allows the RV to contract against, with lower preload and lower afterload as well. And the good thing about the ECMO is that it can be placed at bedside. Again, it all depends on the site and the capabilities overall. The benefits of ECMO overall, as I mentioned, we can shift this curve of the patients that had high RV pressure overload, RV dilation, RV ischemia, and with ECMO or cardiopulmonary bypass, we can then improve the systemic perfusion, decrease the RV ischemia, decrease the RV dilation. Now, what's the data on VA ECMO? Again, there's no randomized controlled trial overall of patients with VA ECMO. It would be very hard to enroll. But what we know from the case series of multiple different sites that report their experience of patients with VA ECMO, we know it's pretty effective at reversing cardiogenic shock and malperfusion. The mortality rates overall are around 30%, but they range about from 9% to 41% in patients who actually receive cardiac CPR. And overall, this higher mortality when it's placed during ongoing CPR versus after the patients have achieved reaching a spontaneous circulation. But what we do know, and similar to the cases you were mentioning, is that failure of systemic TPA leads to higher mortality and higher bleeding. And it's not just because of the TPA itself, but it's just there are patients that typically needing CPR, there's high risk of intra-abdominal bleeding as well because of the ongoing CPR and the ongoing arrest. And it's not without risk. The risk of lower limb ischemia at about 8%, and the risk of stroke about 11% as well. And then when we look at, for example, in our institution, our case series of patients with that were treated with VA ECMO and percutaneous mechanical thrombectomy, these were specifically 9 patients, pretty high risk, about 6 of them with cardiac arrest, with a large RV to LV ratio, elevated lactate as well as 7.6 in average. And all patients treated with VA ECMO and large bore thrombectomy. And we know that the mortality was about 22%, so pretty good case scenario when we look at compared to other series as well. And the ICU day times were about 10 in average. Now, when we look at the national data, this is data from the FLAME study that look at, basically this was a non-randomized, just not even a comparative trial, just looking at patients enrolled in an observational study on the FlowTriever arm that were considered to be high risk, and compared it to just a performance goal or a historical group of patients that were treated with anything else that was not a FlowTriever. And what we can see is that patients in the FlowTriever arm that were considered to be high risk overall had better in-hospital mortality as well as lower risk of complications overall. So what are the key learnings for the operator and the team? What we know is that evidence supports right now an increasing role of VA ECMO and catheter therapies as expertise of the PERT teams continues to expand overall. I think right now what we see in the guidelines overall, the European guidelines, is that for patients that come in with high-risk pulmonary embolism or catastrophic PE would be systemic thrombolysis, just because of the availability overall. But I think as the expertise of the PERT teams continues to expand overall, we'll be able to select patients that would benefit more from VA ECMO and catheter thrombectomies as opposed to getting systemic thrombolytics. But we do need trials that directly compare the treatment modalities of the high-risk PE patients overall. Thank you.
That was a really great review of these high-risk patients. We looked at our center about 371 patients around 2018, the intermediate and high-risk patients. The intermediate risk patient mortality is about the same as it was then. And we didn't have all of these fancy technologies, but we are clearly bringing down the mortality rates for the high-risk patients, and I think a lot of it is probably to credit the coordination of care around these crash and burn patients and these really ultra-high-risk patients. So that was a really nice review, and it's really nice to see in Kobayashi's report that those mortality rates had been hovering in the upper 30% range, and now they're in the 20% range overall. It's just those crash and burn patients, we've still got some work to do.
Yeah, great presentation, Yulanka. I just want to emphasize, the point of, mechanical ventilation can be very harmful in these patients. A dramatic shift in the intrathoracic pressure, the preload. I think that one of the reasons probably this patient crashed was probably that she got intubated. The right diagnosis was not made and she was intubated.
Yeah, that's absolutely correct. We've all seen it. Either EMT intubates the patient on the field or the ER doc intubates them. It's very important, especially if the patient does require mechanical ventilation, that they recognize that the second they give the paralytic or the sedation, the patient's going to get pushed off that cliff and just code. So you have to educate your team. And it's not just your PERT, it's actually your ER docs, it's your EMS.
Nice job. Who's doing the cannulation at your institution, and then who's managing the patient post-cannulation?
This is combined. We do this combined with cardiothoracic surgery overall. So they have the perfusionists overall, but a group of us are able to place patients on ECMO in the cath lab overall. And we have in our main site, we do have a strong ECPR team as well. So we do this in strong collaboration with our cardiac surgery team. But again, it's going to be very different if they're in outlying hospitals or and if they're not on the main site.
I would echo the point about intubation. I think actually it's extraordinarily important to educate kind of everyone in your hospital about this. We've actually had a couple talks now with our ICU docs and our ED docs, and we kind of asked them if someone came in with a PE and they're emergently decompensating, please call us. If you need to intubate them, if you can wait, let's do it in the cath lab. And surprisingly, if you have that, if you're ready for it, you can often kind of chemically get people through the first little bit of it. We'll have people ready for cannulation, but frequently we won't have to cannulate. We can give them some epinephrine and do mechanical thrombectomy. And the beauty of the devices these days is they're pretty fast, and you can often kind of get out of it without actually having to cannulate, but you have to have the ability to cannulate right there.
Brian, you mentioned that you use some other right-sided support, such as RP Impella, Protect Duo, other things like that sometimes in these cases. Does anybody else do that or have experience with that?
Yeah, so we have just very limited experience with RV Impella, and overall, it just seems that it to be very difficult because of access issues overall. And I haven't had personal experience with Protect Duo overall, but it looks like when you have ECMO and ECMO available, that seems to be kind of what we typically need, because we need that, not just the improvement on the RV, decreasing that RV afterload, but also as well the arterial support. But overall, I think that's wide limited experience overall.
So I will give you just a anecdotal experience. We've done this. We're kind of in the midst of writing this up, but we've done 8 cases of RP Impella in PE. 6 of them were getting active CPR as they were getting mechanical thrombectomy in the RP, and we have not had to, and none of them required ECMO cannulation, all of them survived. So it seems to work well if you clear the clot, but that's important. You don't get the hypoxic component. You have to clear the clot, you have to decrease the resistance. But I think this is all institutional driven, and this is institutional driven in our perspective. It's just a faster way for us to get there. And so that's why we've kind of used it, and we've actually found it to be really useful.
The most important point is what you stated, that if you're going to use an RP Impella, remember it sits in the left PA, so you need to clean the clot out of the left PA first, you're going to have problems.
And the other thing is VB ECMO, RP Impella, Protect will unload the RV, but remember the outflow actually still dumps into the PA. So without clearing the clot, you're really not doing the patient any favors because there's still obstructive shock. So if you're providing RV support after your procedure, I think that's a reasonable consideration for patients that aren't improving as dramatically as you like after your thrombectomy or after your catheter-directed thrombolysis. But I think in patients who are truly in that catastrophic category before you are able to do the thrombectomy, that's when I think VA ECMO still remains helpful.
The one quick thing I would add for all of those that are kind of just starting this is, what we learned, I think, early, or at least what I learned early, is that it is really important to understand the hemodynamics of the person leaving the lab. There is occurrences that you will see that you came in and you had a PA pressure mean of 45, and when you left it was 25, and you're, high-fiving and chest bumping, and you cleared the clot, but then you get a mixed venous sat, and it went from 50 to 30. And part of your PA pressure reduction is lack of cardiac output. And in those patients, you have to be very careful about the next 24 hours. And so, I would strongly suggest folks, if there's any concern about hemodynamics of the patient, just make sure you understand when you're done with your procedure where they lie.
Great points, Brian. Actually, we standardized our institutions that we always start with the right heart cath to get the RVTP and CR8 just to reflect how the right side is doing. I think this is extremely important point.
I think Brian's point just is end with the right heart cath. Start and end.
Yeah, I completely agree. We do the same. Those numbers can be a little misleading, though, especially if you haven't given the blood back. You're doing large volume removal. You are changing things. So I will say that if the patient has improved clinically on the table, oxygenation is great, heart rate's normal, blood pressure is normal, and I saw a little drop in the PA sat, I don't get too concerned.
One thing I rely a lot on actually is the pulse pressure before even going to the cath lab. Honestly, for somebody 90 over 40, I'm much more comfortable with that rather than somebody 120 over 100. So the pulse pressure for me is as a man kind of sign how hemodynamically the patient is going probably to do next few hours.
Great comments. Thank you, Yulanka. Tarek, you want to close us out for today? Tarek's going to be presenting on vegectomies using some of these systems that we've introduced today.
Thank you so much. So I'm going to move away from the PE, but we're still using PE devices to deal with this vegetations on the right side. Okay, so first case, this is a 27-year-old lady, 4th month postpartum. She came in short breath, generalized weakness. She found to be in septic shock along with hypoxic respiratory failure requiring mechanical intubation. Her history is IV drug abuse, Hep C, chronic lower extremities, ulcer with underlying osteomyelitis. CT chest, consistent with septic emboli and superimposed aspiration pneumonia. Her blood culture showed persistent MSSA. So this is the echocardiogram. So this is a tricuspid valve. And as you see, there is a huge mass vegetation, about 3 by 3 centimeter on the tricuspid valve going in and out with systole and diastole. So clinical challenge, she has a persistent MSSA endocarditis, large size vegetation. On the Doppler echo, she has multiple severe TR. She also clinically in right side heart failure with septic emboli. So patient came out with a shock, and she was evaluated by our cardiac surgery team. Of course, she's not a candidate because of her IV drug abuse status. So what would be the next step? So this actually was the first case we published in this, the first case on the technique and using PE device as a flow retriever catheter and sucking this vegetation out to help the patient. So basically with this we obtain a right groin access, and we use it under ice guidance. So basically we get 2 access, 9 French for the ice and 24 French for the dry seal sheath. And we go up with the 24 straight, and inside that we put the 20 curved, and we maneuver the 2. So basically by moving the 20 curved push it farther inside the 24, you can control the degree of the curvature you have in the 20 French, and you can still move the whole device in and out just to the levels of the tricuspid, and you can also torque it out. So basically under ice guidance, we try to suck this vegetation from the tricuspid valve, which sit anteriorly in the chest. So this is same patient. This is the top of the catheter now, hugging the vegetation mass, and this is in action as the vegetation getting sucked by the catheter. And the right side panel, you can see that a 3 centimeter vegetation ball is gone. And this is, the pieces that came, they don't come one piece, they come, pieces. But if you look at the ruler, probably they add up to the size of the vegetation that was there. Most of these patients, they get serious reaction in the cath lab because of the release of the bacteria. They get a bit tachycardic, and, but they recover in next half an hour, 1 hour. So ultimately, she cleared her MSSA. She was discharged to rehab facility. So case 2 is a 65-year-old man, multiple recent admission to outside hospital within last 2 months for generalized weakness, poor appetite, falls, and failure to thrive. And, nothing could have been figured out. His history, his EF is 20%. He got an ICD a couple of years ago. He also has history of fem-fem bypass with multiple, infection and surgeries, and requiring prolonged antibiotics. So blood cultures, Corynebacterium, ID was a patient. He was starting antibiotics, and they recommended TEE and PET scan. So this basically, the ICD lead is hard to appreciate, but it's going from the RA at the top to the RV at the bottom. And here you see the vegetation elongated, big size is about 4 centimeter measured, and going from the, attached to the ICD lead, going from the RA into the RV across the tricuspid valve. So EP and CT surgery team were involved. Patient again is not a surgical candidate, multiple comorbidities, high risk. And here we go again using the same technique. You see the flow retriever catheter, and this is what we had come out. And this is post. You can see the ICD lead, but you don't see the mass anymore. And patient underwent later by EP percutaneous ICD lead extraction, discharge in live vest to sniff with 6 weeks of IV antibiotics. So just a background, in tricuspid valve is about 10 to 15% of all endocarditis. The incidence arise because we now implant more cardiac devices like ICD pacemaker, also tunnel devices, in addition to the epidemic of the IV drug abuse. So current recommendation when to operate for these patients, on the left side for the tricuspid valve endocarditis, if they have, hard to eradicate, organisms such as fungi, or if they have persistent bacterial endocarditis. Another indication would be if they have large one, more than 20, some guidelines go by more than 40, which is 4 centimeter. And lastly, if they have right heart failure, that's refractory diuretic treatment. On the right side, the indication when to operate for the lead, the cardiac lead, device lead endocarditis would be if they have a vegetation mass more than 2.5, or of course if they fail percutaneous extraction. So surgical outcomes, surgery is done about 5 to 40%, so not a lot of patients would be candidate, especially if they're IV drug abuse, if they have a lot of comorbidities. And mortality, historically has been, up to 15, 20%, so it's not low. In high experience center, might be as low as 5%, but still considerable amount of mortality. And same for the extraction of the leads. It's, for the ice, it's about 20%, for the pacemaker, and between 0 to 8%. So how this started, it's the first device I used to, treat these in a non-surgical approach was the angiovac. I think, Brian, you published with Dr. Shishehbor a paper on this. I think you guys had a nice case over CCF. And, but it's a very bulky device. It has two large venous bore catheters, 22, and it has a pump, external pump. But it's a very bulky catheter. And actually, there was a meta-analysis of 42 studies, but only 81 patients total. And believe it or not, the mortality from using this device was up to 15%, and conversion to open surgical approach was about a quarter of the patients. So pretty impressive. It's not a benign device. Here we published, this was, I think, in 2021, along with Dr. Shishehbor, one of our surgeons, Dr. Abu Umar, we published on the use of ICE guidance catheter-directed therapy to treat this inoperable tricuspid valve vegetation. Again, this is how the device looks on the outside. From the left panel, you have the flow retriever catheter and you have the ice. On the right side, you have the, again, just how they look and how you can control and point towards the tricuspid valve with ice guidance. And we have done about close to 40 cases so far, and thank God we had 0 complication. So key learning, the growth in technology allows us to offer the previously labeled as no option patients, those IV drug abuse, etc., with some opportunity to recover. The goal here is not, it's not a surgical, so you cannot micro and just take everything out, but at least to debulk and hopefully allows antibiotics to do the rest of the job with the minimal or residual vegetation left in. Of course, more data and hopefully some trials may be needed, but the most important above all, is the interdisciplinary approach. Make sure we involve CT surgery, EP, as appropriate, etc. Thank you so much.
It's really changed the landscape of how we've treated right-sided endocarditis. Does anyone on the panel have any experience treating left-sided endocarditis?
We've removed a couple myxomas and fibroblastomas from the annulus of the mitral valve, but we have not done any left-sided endocarditis.
Do you use sentinel device protection, or how do you do it?
Yes.
Got it.
Yeah, and we did one with a VAC system and one with the ONO system.
So one of our colleagues, Ahmad Yunus, I don't think he's here at this conference, actually has done several combined cases with structural cardiology, where you have to use cerebral protection, obviously, if you're venturing into the left side. But they essentially get retrograde access through the aorta and then do the vegectomy that way. But certainly, perhaps something that we can continue to work on. The important thing to know is that when you're left-sided, the cost is a lot higher if there is embolization, right? So you're not just embolizing purely to the pulmonary artery. You could be, aside from the brain embolization, you could be embolizing into the gut, causing mesenteric ischemia. So I think if we are to move this technology forward towards the left side, that's something that we have to do with a lot of caution.
We've not done left-sided. There was a great case presented yesterday in the structural room about doing it on a bioprosthetic valve and following it up with valve-in-valve mitral procedure for a thrombus on the valve. But one of my concerns, I know the flow retriever here is the fact that it's not continuous suction. And so one of the ways that we've gotten away with not having embolization, and we've talked about when we go to the left side eventually, doing is to start with a hand pull first to get the catheter near the vegetation of the thrombus. Start with a hand pull rather than a full whoosh to engage the clot, such that when you then do a full whoosh, you're more likely to pull it in. The trouble with the syringe-based suction is that as the syringe fills with blood, you lose suction power. And so there's a risk of, if you just go straight up to the clot and try, by the time the clot enters the catheter, you lose your suction power and then it embolizes. So if you start with a hand pull, we've had better success with that way.
I did misspeak a little bit. So we actually, last week when I was on vacation in our institution, they did a aortic valve endocarditis. But it was a non-surgical patient that, their only out was going to be debulking and subsequent TAVR. So, I think we've probably done 4 cases total. But cerebral embolic protection is extraordinarily important. And for the high embolic risk, we actually also just put a balloon up in the subclavian to avoid so we protect the vert. And then, to Sam's point, you have to be, at least in the mitral cases that I've done, you have to be very sure that you're coaxial with it before you pull to make sure you're engaged and you're not kind of sideswiping it.
And as Tarek highlighted, really this is a multidisciplinary approach. We certainly don't live in a silo in PE world, so we don't live in a silo in endocarditis either. Involve your CT surgeon, involve your infectious disease physicians. So I think with that, we're just 2 minutes over. So lunch programs are coming up. If you have any questions, the panel will be around. Thank you.